Hello, my name is Stephanie Villalobos. I am a physician assistant who works in the neurovascular ICU and in the neurotrauma ICU. Today, I will be giving a lecture on subarachnoid hemorrhage. So, in general, what type of patients does a subarachnoid hemorrhage affect? So, non-traumatic subarachnoid hemorrhage causes about 3 to 5% of all strokes. Unfortunately, usually these patients that are affected tend to be your younger patients. They have a very high morbidity rate and also mortality rate, especially if the subarachnoid hemorrhage is a higher grade, which we're going to discuss in the upcoming slides. So average age is about 50, and some of the risk factors for subarachnoid hemorrhage include hypertension, so uncontrolled history of high blood pressure, smoking, alcoholism. The patient has any type of personal or family history of subarachnoid hemorrhage or any type of aneurysms, history in the past, genetic diseases like autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, sickle cell disease, Marfan syndrome, fibromuscular dysplasia, so any type of tissue abnormality or vascular abnormality. Also, some pathomimetic use like cocaine and amphetamine use is going to be a big one also. So what are some of the primary causes of subarachnoid hemorrhage? So for our primary subarachnoid hemorrhages that are non-traumatic, 85% are going to be aneurysmal, which are going to be your most common ones, usually what you read about in textbooks, right? You can have different types of aneurysms. You can get your sacral aneurysms, fusiform aneurysms, Barry aneurysms, and that's a picture there of a ruptured aneurysm. 10% are perimesencephalic hemorrhages, usually also known as your prepontine subarachnoid hemorrhage. They result from bleeding from a venous origin that's usually centered in the perimesencephalic area. And then 5% can be due to other type of vascular malformations, whether it's arteriovenous malformations, dural arteriovenous fistula, arterial dissections, or moyamoya disease. Now, there's also secondary causes of subarachnoid hemorrhages. Trauma is usually going to be the common one you're going to see in the neurotrauma ICU or surgical trauma ICU. So usually it'll be a patient that's involved in an MVA, and they have also a traumatic brain injury, or they also have some type of subdural or epidural hematoma, and then they also have a subarachnoid hemorrhage. Other causes are going to be RCVS, or your reversible cerebral vasoconstriction syndrome, PRES, your posterior reversible encephalopathy syndrome, usually secondary to like high blood pressure. Common in your patients have kidney disease, cerebral venous sinus thrombosis, so just like it sounds, a clot in your cerebral venous sinus, or any type of cerebral veins, cerebral amyloid angiopathy, pituitary apoplexy, CNS vasculitis, primary intracerebral hemorrhage with secondary extension to the subarachnoid space. Tumor is going to be a big one, so that's going to be one of the things that you also want to rule out in a patient that comes in with a subarachnoid hemorrhage is malignancy, coagulopathy, sickle cell disease, mycotic aneurysm, especially your IV drug users. It's usually secondary to a septic emboli that just goes and flicks off and just breaks. And it's usually from endocarditis. Vertebral artery dissection that extends intracranially, iatrogenic injury to any type of cerebral vasculature also. So how is a patient going to present that has a subarachnoid hemorrhage? Like we said, most of these patients unfortunately are going to be young, women, also the majority of them. So textbooks, it's going to be your thunderclap headache, and usually the patients can describe it as the worst headache of their life. Now you want to make sure that you also categorize how much does this headache hurt, right? Because you can have patients that come in that have a history of migraines, and sometimes they say that this is their worst headache of their life, but you also want to look at the whole picture. So usually it's going to be acute thunderclap headache. They can also present with meningismus, usually develops more gradually. So they'll have nuchal and some neck pain, photophobia also, and then sometimes they'll have elevated ICP symptoms and signs. For example, emesis like vomiting, reduced consciousness, or the higher grades that you have subarachnoid hemorrhage, they'll come on stuporous or even in a coma. And then they can also present with focal neurological symptoms, so hemiparesis, aphasia, pupil or extraocular movement abnormalities, cranial nerve 3 palsy, usually from aneurysmal compression of the brain, cranial nerve 6 palsy, also from elevated ICPs. So any type of symptom that you see that you're concerned for elevated ICP, like I said, emesis, stupor, coma, usually these require a stat evaluation for any type of EVD. For concern for like hydrocephalus. Seizures also, usually it's present in about 20% of patients. Now, in the upcoming days of subarachnoid hemorrhage and the higher grade, you're going to see things like neurogenic pulmonary edema and cardiac arrhythmias. during their ICU stay. Usually with the cardiac arrhythmias, you'll see SC segment elevations or T wave inversions, and usually these SC segment elevations resolve, but sometimes the T wave inversions can appear and persist for months or years. Sometimes nursery will call you and they're freaking out because they got an EKG randomly on a patient and they think the patient's having like an end STEMI or STEMI. No, it's probably just secondary to these cardiac arrhythmias that they get. That is just secondary to the sympathetic storm that's happening in their body, secondary to their brain and the subarachnoid hemorrhage. And then you can also get sudden death with these patients. So big thing, like we said, is we want to know the subarachnoid hemorrhage grading scales, especially if you rotate through the neurovascular ICU. Subarachnoid hemorrhage severity is usually expressed with various scores as shown here. The Hunt test score is usually easier to apply, and it's more widely used than the World Federation of Neurosurgical Society score. The weakness with the score is that the patient's mental status sometimes can be obtunded by hydrocephalus. So sometimes the patient will come in with a Hunt test score of 4, and then after they place an EVD, they'll go down to like 1. They're like walkie-talkie. They're like stuporous, not answering your questions. You're having to sternal rub them, and then you place an EVD in them, and then you just see their eyes open, and they go from 4 to 1. So it's kind of one of the downfalls of this. So that's why it's important that neurological status after initial resuscitation and hydrocephalus management is more important than the initial presentation of the patient. So grades 1 through 3 are usually referred to as a good grade subarachnoid hemorrhages, whereas 4 through 5 are usually your poor grade subarachnoid hemorrhages. This is kind of misleading because sometimes patients that come in with a good grade, so a subarachnoid Hunt test score of 1 or 2, can be very sick and can have an increased mortality rate later. So they can go 1 to 2 and then can go and progress to 5 or 4. And then you have the modified Fisher scale also. It just kind of measures the size of the bleed on the scan and can give you the risk of the vasospasm that the patient will have in the upcoming days during their ICU stay. So how do you diagnose a subarachnoid hemorrhage? So CT scan, non-contrast, is going to be your standard initial test that has a 100% sensitivity rate. This is usually a 100% sensitivity rate within 6 hours of a headache onset. You can also get a CTA. This is very sensitive and very specific, has about 95% specificity for any type of aneurysm detection, but it can sometimes miss your smaller aneurysms. Now, so you've got a CT head and your CTA head and neck also, and it doesn't show an aneurysm, but you're still concerned that the patient does have a subarachnoid hemorrhage. You can get a lumbar puncture, and usually you'll look for things like xanthochromia as shown in this picture. And this refers to the yellow hue that's noted on the cerebral spinal fluid that occurs secondary to RBC breakdown. It's usually present after 12 hours. And the other things you can do with these patients is you can get an MRI and or an MRA. And usually an MRI is useful to detect any type of underlying pathology that might be causing subarachnoid hemorrhage. Like, for example, if you're looking for arteriovenous malformations, any type of infection, malignancy, or inflammatory disorders. And then for patients that have a subarachnoid hemorrhage near the base of the brain and you have no source of bleeding, you can also get a cervical spine MRI to see if there's any type of spinal source of bleeding. Other things you can do to diagnose a patient and also to do any type of intervention is going to be your invasive angiography or your DSA, your digital subtraction angiography. Like we said, it helps as a diagnostic role. So if you have a patient that comes in and you're concerned with a subarachnoid hemorrhage and you got a CTA and a CT head and it doesn't show anything, you can get a DSA or an invasive angiography to see if there's any type of aneurysm or any type of vascular cause that might be causing the subarachnoid hemorrhage or the bleeding. And this is going to be the gold standard. So once again, DSA is going to be the gold standard for detection of aneurysms or any type of cerebral vasospasm, which we're going to discuss in the upcoming slides. Now, how does this work in an interventional role? So it helps for interventional embolization of aneurysm. So they've looked at the aneurysm and they can treat it to prevent bleeding. So this can be done via coils, stent-assisted coils, or there's these newer web devices that are like woven mesh devices that are designed to minimize the need for any type of stent. And then patients that have a post-subarachnoid hemorrhage vasospasm, you can also do a DSA or an invasive angiography for local infusion of vasodilators and angioplasty. So you can treat the vasospasm. Sometimes these patients will get an angiography and it'll be negative. So they'll have an angiography negative subarachnoid hemorrhage. Usually these patients are still managed under the assumption that they have an unidentified aneurysm that has rupture, but they just were not able to see on the angiography. So you have a patient that has a subarachnoid hemorrhage, say they're grade 3, and then all of a sudden, a hunt test grade 3, and then all of a sudden they had a severe neurological deterioration, right? So they're superish now, or they're not, or they're altered, they're not answering your question. Some of the common causes of this is going to be an aneurysm or bleeding. That should be definitely in your differential. It's highest early on, and usually deterioration is very rapid and dramatic with these patients. Other things are going to be hydrocephalus, increased ICPs. Usually you'll have an EVD that will help you measure the ICP values. You can also get delayed cerebral ischemia that occurs about 3 to 14 days after the subarachnoid hemorrhage, and it peaks at 7 to 10 days. And then you can also be concerned for seizures or non-convulsive status epilepticus, which is going to be the big one. So it means that seizures that you can't catch on the physical exam. So you'll have to get an EEG. Shock or hypotension, right? Because usually with hypotension, you're going to get inadequate cerebral perfusion pressure. And when we think about cerebral perfusion pressure, we think about the cerebral perfusion pressure equation, which means mean arterial pressure minus ICP. So if they're hypotensive and their mean arterial pressure is low, then they're not going to be adequately perfusing the brain. So differential diagnosis for like any type of hypotension would be Takotsubo's cardiomyopathy, which is just secondary to the sympathetic storm that the patient's having, secondary to the subarachnoid hemorrhage, adrenal insufficiency, medications, right? For example, sedation. And one of the reasons why we also try to avoid narcotics for these patients, such as like oxycodone, Dilaudid, and morphine. Infections like ventriculitis, given the fact that they have EVDs, fevers, whether it's a central fever that's coming from the brain, from the hypothalamus that is just has been damaged, or just an infection. Any type of metabolic derangements, also hypoglycemia, hyponatremia. Also, that's why in these patients we aim for sodium greater than 145, hypercapnia, uremia. So evaluation, you want to get a BMP, right? Look at the sodium, get a finger glucose, ABG, cerebral spinal fluid. Go to the bedside and assess the patient. That's going to be the biggest thing. Get your neurological exam. Just because the nurse calls you, the patient's altered, go to the bedside and assess the patient. Also, if the patient does have an EVD, look at their ICP trends, right? Is it trending up? You can also consider a CT scan if you're concerned for hydrocephalus or intracranial hemorrhage or aneurysm or bleeding. You can get a CTA if you're concerned for delayed cerebral ischemia, and an EEG if you're concerned for non-convulsive status epilepticus or those silent seizures that you can't see on a physical exam. So vasospasm is something that's really important that you have to be aware of for any type of patient that has a high-grade subarachnoid hemorrhage, or I would just say in general, any patient with a subarachnoid hemorrhage. So vasospasm occurs in about a third of the patients, and it's the leading cause of morbidity in patients who survive their initial subarachnoid hemorrhage. So a patient can come in with subarachnoid hemorrhage and usually, unfortunately, die from all the consequences that they have from the subarachnoid hemorrhage. And like I said, vasospasm is going to be the big one. And what you need to know about vasospasm is that it occurs 3 to 14 days after a subarachnoid hemorrhage, and the peak risk is around 7 to 10 days, and it usually resolves by day 21. And that's why our patients with a subarachnoid hemorrhage stay in our ICU for a very long time, because you want to make sure that they don't have a vasospasm. They can stay with us up to day 21. And unfortunately, if they vasospasm once, they're going to continue to vasospasm multiple times. And like I said, it's going to be more common in your higher grade, like your Hunt test 4 and 5 subarachnoid hemorrhages. So some of the risk factors are going to be high volume of subarachnoid hemorrhage blood in the brain, intraventricular hemorrhage, younger age, what's the etiology of the subarachnoid hemorrhage, right? And about 25% of these patients have tissue ischemia, because subarachnoid hemorrhages, it's basically where there's red blood cells that break down, they release all these chemicals that kind of piss off the cerebral vasculature, and it causes them to clamp down, and that can give you stroke-like symptoms because you're decreasing, right, oxygen blood to the brain, and that's why it causes delayed cerebral ischemia. And that's why it's important to whenever you're presenting a patient, know what the subarachnoid hemorrhage Hunt test score is, right? 4 or 5, modified Fisher score. And also, I want to know what bleed day are they, right? Bleed day 5, bleed day 6, bleed day 7, bleed day 8, right? When was the first day they presented, and count from their bleed day, because that's going to tell me what risk they are for vasospasm. So I keep talking about delayed cerebral ischemia. How do you prevent delayed cerebral ischemia? Well, you prevent it by preventing vasospasm. And the biggest thing is going to be nimodipine. Nimodipine is probably the only evidence-based, class 1 evidence-based medication that's known to prevent vasospasm and to prevent delayed cerebral ischemia. Dosing is usually 60 milligrams Q4 hours, and this patient gets this throughout 21 days that they're in the ICU with us. But usually, sometimes some of these patients get a very robust response to nimodipine because it's a calcium channel blocker, right? It can cause hypotension. And so usually these patients, we can split up the dose to 30 milligrams Q2 hours. That way they're not getting a huge dose and it's just dropping their blood pressure. And then also maintain euvolemia. That's why it's important to look at their eyes and nose, how much urine output and intake are they having, and you want to kind of keep them equal, not too much fluid, right? Because they can get pulmonary edema. But you also don't want to keep them very dry. You want to keep those cerebral vessels super plump to decrease the vasospasm. So how do you prevent this? So with nimodipine, you also want to do surveillance, serial neurological exam. So usually this patient will have they'll be stuporous, they'll have an acute change in their mental status. So that's one of the things you want to take into consideration. You can also do transcranial Dopplers, which we do for these patients, or TCDs are done daily, and continuous EEG also. And like we said, nimodipine, that's going to be what you need to know. It's a dihydropyridine calcium channel blocker that is known to prevent vasospasm, which causes delayed cerebral ischemia. So diagnosis, we said focal neurological findings. So if you have a patient, they're concerned for vasospasm, DCI, get a CTA and CT head, and then a CT perfusion. You can get MRI. Gold standard for this, like we said, is going to be invasive angiography, especially for your large vessel vasospasms. Usually with these patients, sometimes they'll also present with like mental status changes, and then also they'll have they were fine with their blood pressure, and then they'll get super duper hypertensive. Don't treat the blood pressure in these patients, right? They're trying to perfuse their brain. Their blood pressure can be in the 220s, 230s. With an exam change, high grade subarachnoid hemorrhage, their bleed day like 10, you're concerned for vasospasm, right? So with these patients, don't treat the blood pressure. They're trying to augment themselves. Give them a bolus of plasma, a liter, to keep those vessels open, right? So how do you treat these patients? Treat hypovolemia, like we said. MAP elevation also to increase cerebral blood flow. Like we said, CPP is what? MAP minus ICPs. If an EVD is in place, open the drain to a lower pressure, and this can reduce ICP and also improve CPP. Neurointerventional radiology therapy is usually like the best treatment for these patients, because they go in there, like we said, the DSA, digital subtraction angiography, and they actually go into the cerebral arteries and they inject vasodilator administration, or they can do angioplasty. The other thing is going to be systemic milrinone infusion. So if a patient has had multiple episodes of vasospasms, they'll start them on a milrinone infusion. And usually the milrinone infusion that we start them on is pretty high in comparison to the milrinone infusion you use for patients for our cardiac patients. So usually for cardiac patients, I think it's 0.125. For ours, we start them at 0.25. I've seen it up to 1.25. So it's pretty high doses. And usually these patients are going to be on both nimodipine, which is a calcium channel blocker, milrinone, and then also they'll be on a vasopressor also. But the big thing with this is going to be the triple H therapy, right? Hypertension, hemodilation, hypervolemia. Unfortunately, that's one of the things that a lot of older textbooks show. We're trying to kind of stay away from that now, because what was happening is that these patients were getting a lot of volume. And like we discussed, one of the side effects that a subarachnoid can have in patients that have the higher grades and the longer they stay in the ICU is going to be pulmonary edema. So they get a lot of fluid. They can go into acute respiratory failure. So that's why you want to be very judicious with your fluid. So only hypertension is going to be beneficial. But the primary advantage of just angiography is that you're able to provide immediate therapy. So that's going to be the best management. But if you have a patient that you're concerned for vasospasm, give them fluids, right? and call your friendly neurosurgical colleague. So one of the big things you're going to deal with in the ICU is going to be analgesia. Subarachnoid hemorrhages are very, very painful. These patients have very, very bad headaches throughout their days in the ICU that they stay with us. Usually, we try to avoid NSAIDs in these patients due to risk of coagulopathy and renal dysfunction. Since a lot of these patients are getting CT scans back and forth throughout the day, we want to make sure that their kidneys are okay. And you want to minimize opioids. Why? That's the biggest thing that a lot of the residents ask me, is because they're not effective for any type of meningeal pain, right? So usually these patients have headaches, but secondary to the meningeal pain that is secondary to our subarachnoid hemorrhages. So opioids are not going to work. First off, they're going to decrease the mental status of the patient, right? They may cloud your neurological exams and they're just not going to be effective. So things you can use for these patients are going to be Tylenol, gabapentin, right? And this is great because we said that you're having that ongoing meningeal irritation that's causing your headache. You can give also migraine cocktails, so things like metoclopramide, prochlorperazine in combination with magnesium and or some type of diphenhydramine. But magnesium is going to be usually your friend. I love magnesium. Magnesium is just so good, and it's very hard to get a patient too much magnesium to get them at levels that are super toxic. So if a patient that has a headache, I try mag first, like 4 mag. You can also do valproic acid in patients that have failed everything else. But the big thing for these patients is minimize opioids, right? Because that headache is usually secondary to the meningeal irritation, and opioids are not going to be effective, and they're going to cloud your neurological exam. Some other things that you're going to see a lot in these patients is going to be hyponatremia. It's very common following aneurysmal subarachnoid hemorrhages. Some of the causes are going to be cerebral salt wasting, SIADH, or syndrome of inappropriate antidiuretic secretion, or how one of my favorite attending calls it excessive antidiuretic hormone, which I think has stuck better than SIADH. Hypovolemia, to include cerebral salt wasting syndrome, like we said, adrenal insufficiency due to the hypothalamic and pituitary axis dysfunction, pseudohyponatremia. So you have a patient that has a low sodium. It's really important that we keep the sodium high in these patients, right? Because it decreases cerebral edema. So how are you going to investigate these patients? So the big thing is your volume status, right? Volume status is going to be the key. Go to the bedside, assess a patient, do look dry, although sometimes it's difficult to assess a volume status in our ICU patients, but there's multiple things you can do. So you can do ultrasound, right? Look at their IVC, look at their IJ, right? You can do the passive leg raise. You can look for skin tenting, look at their mouth to see if it's moist. So there's multiple ways you can look for volume status. You can also send some labs, so urine sodium, urine lights, and urine osmolality, serum osmolality, and cortisol levels. This will kind of help you investigating to see what is the hyponatremia due to. So hyponatremia is usually going to be either secondary to SIADH, so the patient's euvolemic, right? Or it's going to be secondary to cerebral salt wasting syndrome, which is where the patient is hypovolemic, right? They're losing both sodium and water, and not just retaining water, which is what SIADH does, right? So that's why volume status is going to be the big thing for these patients. So how do you manage hyponatremia in your subarachnoid hemorrhages? So hypovolemia can precipitate vasospasm, like we discussed, right? We talked about our Triple H, right? Even though it's kind of not as pertinent now because there's more data coming out and literature coming out that we're pushing these patients into acute respiratory failure. But you also kind of want to be judicious with their fluid. But hypovolemia can precipitate vasospasm. So you want to avoid fluid restriction or diuretics during the vasospasm window. So unfortunately, you can't treat hyponatremia. Sometimes these patients have hyponatremia also because we're just like giving them so much fluid. Sometimes we're positive 10 liters in a day or 5 liters. So we're just giving them a lot of fluid. So unfortunately, we can't diurese these patients. So usually with these patients, you can do hypertonic therapy. That's going to be your best one. So you can do, for example, 3% saline bolus, like 250 cc's, 500 cc's. Because worsening hyponatremia can be a big threat to the brain. You also want to evaluate and treat for adrenal insufficiency. If the patient's hypovolemic, you can treat also with isotonic crystalloids like plasmolite. Cerebral salt wasting syndrome is a big one that I didn't learn in school, so that's why I decided to just add a slide about this. And the existence of cerebral salt wasting syndrome, it's pretty controversial. We really don't know what the pathophysiology is. And it's sometimes, like I said, it's difficult to differentiate between cerebral salt wasting syndrome and SIADH. We think it's secondary to aldosterone deficiency that occurs in some of our patients with subarachnoid hemorrhages. And this explains why the treatment for these patients with cerebral salt wasting is exogenous steroids like fludrocortisone or hydrocortisone, because the mineralocorticoid effect is very helpful. The big thing, though, with these patients that do have cerebral salt wasting syndrome, right, they're peeing both urine and water, treatment's going to be fludrocortisone, and sometimes it can cause hypokalemia. So make sure you look at that potassium level. So, like I said, treatment's going to be treating the hyponatremia with hypertonic therapy, treating also the hypovolemia with both isotonic fluids and fludrocortisone. Usually the dose is going to be for fludrocortisone 0.1 to 0.3 milligrams PO BID. And usually these patients can develop cerebral salt wasting syndrome by hyponatremia, polyuria, so they're peeing out a lot. And you'll see if you send like urine studies, you'll see urine with high osmolality and high sodium concentration. That's kind of what will tell you that the patient has cerebral salt wasting syndrome, and you can differentiate that from SIADH. Well, I hope this lecture was helpful for you in regards to subarachnoid hemorrhages. I think the pathophysiology for subarachnoid hemorrhages is just fantastic. You'll see a lot of, unfortunately, in your high-grade subarachnoid hemorrhages with grades that are 4 and 5. You'll get to use a lot of your physiology and your anatomy that you learn in school. So you'll see things like Takotsubo's cardiomyopathy or broken heart syndrome or stress cardiomyopathy, secondary to the sympathetic and parasympathetic imbalances that happens when you have any type of brain injury. You'll have things like neurogenic pulmonary edema, which I know about, also vasospasm, delayed cerebral ischemia, SIADH, and also cerebral salt wasting. So we think about it's just a brain injury, but it's because it really affects the entire body. So we're excited for you to rotate with us in the neurovascular ICU and neurotrauma ICU and really use and utilize all that medical physiology and pathophysiology that you learned in school. I hope this was educational for you. Thank you.